So good afternoon, everyone. My name is Maria Bucur, and I'm pleased to present to you my 12 months progress related to my PhD topic, Diabetes Mellitus across pancreatic diseases. I'm a third-year resident doctor in diabetology in Bucharest, Romania, and I'm here in a bilateral contract between Carol Davila University in Bucharest and Semmelweis University Center for Translational Medicine. Since I'm a diabetologist, my vision is to decrease the burden of diabetes mellitus, and my mission at the moment is to improve prognosis of pancreatic disease patients by achieving well-controlled diabetes. In order to achieve my mission, I have two ongoing projects. First, I would like to find out what is the best method to prevent diabetes. And secondly, I would like to investigate the beta cell function during acute pancreatitis. Let me introduce you now into my first topic, investigating therapeutic options for preventing or delaying diabetes mellitus in prediabetic patients, a systematic review and a meta-analysis. First of all, prediabetes is the term used to describe a population whose blood glucose levels are above the normal range, but that do not meet yet the criteria for diabetes. And as you can see, more than 470 million people will have prediabetes by 2030. Moreover, 5 to 10% of them will progress to diabetes mellitus yearly. So they will develop a chronic disease that will also impact the healthcare system. At the moment, the American Diabetes Association recommends that we implement lifestyle modifications that can reduce the risk of progression to up to 70%, and it is also better than treatment with metformin. Currently, the FDA doesn't approve any medication for treatment of prediabetes, but as you can see, probably know, newer drugs have been approved to treat obesity. So in this context, we want to identify the most efficient intervention for preventing diabetes mellitus progression in patients with prediabetes. And we started our research with the following clinical question: what is the most effective intervention that can prevent or delay diabetes in prediabetic patients? And we want to investigate adults with prediabetes that are given any type of intervention that may reduce the risk of progression. And our outcomes are diabetes mellitus incidence and the changes in hemoglobin A1C, fasting plasma glucose, and oral glucose tolerance test of glucose levels. We only included randomized controlled trials, and our hypothesis is that lifestyle modifications are followed by a greater risk reduction than pharmacotherapy. Using the following search key, we searched 3 major databases, and we ended up with 331 articles plus 28 articles found by citation chasing. And I would like to present to you some preliminary results for one of our outcomes, which is the hemoglobin A1C, which is a blood work that show us the levels of glycemia that a patient has had in the past 3 months. It can be measured in millimoles per liter or percentages, and for this analysis we used percentages. And in this forest plot, you can see the treatment with GLP-1 compared with placebo. The measure of effect is the mean difference, and we obtained a mean difference of minus 0.25 percentages, which means that the GLPs lowered the hemoglobin A1C with more than a placebo with 0.25 percentages, which is almost clinically significant, because we know from the literature that a reduction of more than 0.3 percentages is considered clinically relevant. This result is also statistically significant. In the second forest plot, we can see the treatment with metformin versus placebo, and we did 3 subgroups based on the follow-up period, so at 3 months, 6 months, and 12 months. The measure of effect is the same, the mean difference, and we can see that at 6 months, the mean difference was minus 0.75, meaning that metformin treatment decreased the hemoglobin A1C more than the placebo by 0.75 percentages, which is clinically significant. Unfortunately, we did not achieve yet statistical significance, but as you can see, there is a clear tendency that metformin reduces hemoglobin A1C, because all of the articles are on the left side of the line of no effect. Also here we can see that at 12 months, it appears that the effect of metformin is lost. In the third forest plot, we analyzed aerobic training versus control. the same measure of effect, the mean difference, and here we obtain the mean difference of minus 0.45%, which is clinically significant. However, it's not yet statistically significant, but the same thing, all the articles are on the left side of no effect, which means that it is a clear tendency that aerobic training reduces hemoglobin A1C. The same thing for the resistance training, where we obtain the mean difference of minus 0.28%. So our analysis is still ongoing since we have a lot of articles included, and we want to analyze all classes of antidiabetic drugs, plus lifestyle intervention, diet, and physical activity separately, and in the end to perform a network meta-analysis. Our meta-analysis will be the most comprehensive meta-analysis on the topic so far, and we will include new drugs such as the GLP-1 and the SGLT2s, and we will use a high-quality methodology. However, we face some limitations as well, such as the heterogeneity of the interventions and placebo being frequently used as a comparator. As some preliminary conclusions, we can say that GLP-1 agonists reduce the hemoglobin A1C by clinically and statistically relevant levels. Metformin reduces hemoglobin A1C by clinically relevant levels after 6 months, but not after 1 year, and training reduces hemoglobin A1C by clinically relevant levels at 1 year. And as implication for practice, we can say that these data suggest the long-term routine administration of metformin is not justified, and the long-term effects of training seems to be superior than metformin treatment. As implication for research, we need further studies in order to look at dose dependency and longer time administration of the drugs. Regarding my progress so far, we are still waiting for further figures and tables, and we started to write the introduction and methods of the manuscript. Moving on to my second topic, investigating the time dependency of beta cell function failure during acute pancreatitis. This time will be a registry analysis. And I would like to start by inviting you to imagine a very simple and very usual clinical case that presents to the emergency room, a patient with abdominal pain with criteria for acute pancreatitis and also hyperglycemia. And we will see that the levels of glycemia are important in the prognosis of acute pancreatitis. And how are we treating this? Because the guidelines have no recommendation on the insulin treatment, meaning no recommendation of the route of administration or the dosage. So this justifies the need for my second research topic. As I said, stress hyperglycemia is very common in AP. More than 50% of cases will develop this stress hyperglycemia during the course of the disease, and it is independently and dose-dependently associated with AP severity and mortality. Organ failure is seen in 20% of cases of AP, and it's mostly reversible, and major organs have been widely investigated. However, there is scarce data on the beta cell function during AP. So our aim is to evaluate the beta cell function in AP patients, and this function can be measured either directly by measuring the C-peptide levels or indirectly by measuring the total dose of insulin needed in order to maintain normal blood glucose levels during the disease. So we started our research with the following clinical question: what is the time dependency of beta cell failure during the course of AP? And since we are interested in the endocrine function of the pancreas in patients with acute pancreatitis, we want to look at adults with pancreatitis and to examine their glycemic levels during the course of the disease, with the outcome being insulin administration, meaning the total dose of insulin used and the day and the route of administration. And we hypothesize that there is a time dependency in insulin necessity during AP, meaning in the early phases there is a high insulin necessity, and in the late phases there is a low insulin necessity. The clinical implication will be that we will understand better the dynamics of beta cell function, and we can provide evidence-based recommendation for insulin treatment. For this research, we would use the AP registry that contains more than 4,000 patients, from which 680 patients received treatment with insulin, and almost 1/3 of them did not have diabetes prior to the admission. In summary, I have 2 ongoing projects that I hope to finalize by the end of 2025. And I'd like to thank for your attention with a quote from William Osler: "Medicine is a science of uncertainty and an art of probability." Thank you.
Regarding the aerobic activity, the aerobic training, is there any adjustment for patient characteristics, or
Patient what?
Patient characteristics, or are there any exclusion criteria for patients to undergo aerobic training?
No, we did not adjust for any patient characteristic, but since they are very similar in body weight, if that's what you mean, or
yes.
age, or yes. And the second part of the question?
If there is exclusion criteria for including patients in aerobic training?
No.
Okay. Thank you.
I have a question regarding your first topic. You compared the GLP-1 analogs with placebo and you measured hemoglobin A1C decrease, yeah? Mm-hmm. So do you have data about the hypoglycemic events?
We also collected the adverse events, and we are currently analyzing them. I can say that in the studies there were not many hypoglycemic events reported, but in the end we would want to have an analysis on all adverse events reported for all the drugs, so we can have we can clearly see the benefits and the risks, of course, of administering a drug.
Thank you very much.
Okay, thank you. Any other questions? I would like to ask if you saw anything when you did all this analysis regarding the metformin. The side effect, the diarrhea, this is what I have in my mind.
Yes, the most common side effect in metformin were gastrointestinal complications like diarrhea, flatulence, or abdominal pain. But as I said, the analysis is currently ongoing, so I can't tell you how frequent there were, but they were reported in a lot of...
Yeah, this would be very interesting to see.
Yes, but although after some time passes after the treatment, these adverse events fade away, so...
Okay, thank you. Any other questions? Yes, please.
Would you like to examine the role of surgical solution in the prevention of diabetes formation?
Do you mean bariatric
surgery?
Unfortunately, I did not find enough articles with this intervention, so I think I don't even have one. So.
Yeah, but this is very important regarding the topic because the indications are getting looser. So more and more patients are being obese patients or pre-diabetic patients are being evaluated for bariatric surgery.
Yeah.
And in your country, the GLP-1 analog therapy is indicated for the therapy of prediabetic conditions?
No. But since we have these results, maybe we can have new recommendations.